Very good morning to everyone, and I thank CAS for giving me this opportunity. So this PCL avulsion is more of discussion based, depending on the different steps in PCL avulsion management. So first I would like to put to the panel, like, in case of PCL avulsion, how good is the clinical examination of these patients? Because most of these PCL avulsions, they come in an acute scenario. So we rely on imaging or more of a clinical examination. It's open to the panel. In diagnosing these cases.
Yeah, of course, clinical first.
Okay, sir. So it's by SAG sign, posterior droits, routine one, or any special test we do?
Even before that.
Just simple clinic.
If there is a history of fall from motorcycle,
yeah,
especially in flexed knee, if the patient can remember that, sometimes they do remember, and there is some telltale bruising in front of the knee, around the patella, there can be ecchymosis, etc. So that draws our attention that there may be something wrong inside the knee joint, and often in contrast to ACL, they do not often complain about instability.
Exactly.
They tell that something is wrong inside the knee joint. So and sometimes they ignore that. Sometimes the general practitioners also ignore that, and they come as a late presentation of ACL in PCL.
Most of these patients may complain of pain and discomfort rather than instability in the acute scenario.
So I'll just chip in.
Yes.
What Gurdar said, besides that, the sign of exact location, there are two places. One is around patella, but around patella, to be more specific, what I have seen is, it is below the patella.
Right.
The impact on patella will go directly on femur. The impact below the patella, around tibial, early edge of the tibial condyle or somewhere below that, will go on the PCL. Tibial tubercle. On tubercle to the edge of tibia. That is where exactly it comes.
That pushes that.
Second is, in acute phase, you will not be able to do these signs.
Yeah.
In acute phase, there is hemarthrosis. And hemarthrosis in a knee where patient is walking normally, almost normally, and then you suspect a fracture somewhere. It can be a condylar fracture, it can be an avulsion. And an X-ray, of course, later on will tell you something. Besides this, the only issue which the patient faces, besides hemarthrosis sometimes it is a quiet knee also. So in acute knee, your clinical tests are probably, these two are not going to be very easy to elicit. Then you have to rely on your X-ray or your bruise. These are and the pain in the posterior part of the knee. That's what I divide into acute and chronic. And then we classify this for the tests.
Right, sir. Thank you. So next comes the imaging. So apart from the X-ray lateral view, so why we take CT or MRI and what we look for that? Samantha, sir.
So imaging, whatever you take the normal X-ray. Most of the time with the X-ray,
sometimes we miss it.
Even with the AP, you have to be very suspicious because there is a cracked line which you can see in the AP X-ray, and if in the just below the two eminences there is a small break.
Yes.
Then if it is a frank fracture, probably like this in the X-ray you can diagnose. Or if there is once the pain is diminished and the classic signal what Gaur sir and Dr. Vikas told, that if there is any bruise just around the tibial tuberosity or below it, you must suspect that, and the knee is not bending, it is usually hemarthrosis, you must suspect that there is a PCL avulsion or PCL injury. So you do a normal X-ray, then you do a normal MRI because you have to exclude the other injuries. And once you are very sure in the MRI, then probably you can add on the CT scan for your purpose. But X-ray and MRI is the routine.
Right. So next question comes, when to operate these patients?
Whenever you wish to operate, you
timing for surgery.
Timing for surgery. Timing for surgery means it is just like it's not like the ACL. It has to be quiescent like the ACL that some people believe that 1 week, 2 weeks or 3 weeks time. If it's a big chunk, singular chunk for the PCL, the once you investigate, you can as early as possible, you can fix this with a classic posterior approach Lobenhofer. You can do it, or else you can do the arthroscopic job. But if you want to do the arthroscopic job, it is better to wait for 7-10 days so that you don't extravases in the calf.
Yeah.
But if you do it open, you can do it by 3-4 days, 7 days time, no problem.
That's. So does it change if it is associated with other injuries, like other collaterals or meniscal, anything?
No, then it
isolated PCL avulsion with other.
No. If it is associated with the other corner injuries, then that is a different ball game, because if you have to treat also the corners. The classic teaching lab like the Laprade and all the articles like the MKLI, you have to treat the corners. So you can wait till 10-12 days maximum. Because if it is beyond 2 weeks, 3 weeks time, then you won't be able to stitch them, you won't be able to identify them. That is the problem. So it has to be below 10 days.
10 days. Vikas sir.
I have a decent number of cases which I have seen and operated in the last 25-30 years. Now, I have failed to see many associated injuries in a classical PCL avulsion fracture. It's a unidirectional injury, it's a straightforward direct impact injury, so any twisting or rotations are usually not happening in this injury. Therefore, I don't know how many of you have got experience of other ligaments getting injured, but a PCL avulsion injury, I think most of us would have seen 95% in isolation.
Yeah.
So therefore, there is no point if we try to sort of create a situation where it's very difficult to have a situation like that. And then it is a huge fracture.
Yeah.
Then it is no more a subtle
multi-ligamentous. So does fragment, size of the fragment or the displacement, does it matter in our management?
I think it does. The first thing that I want to emphasize is not all PCL avulsion needs surgery.
Yes.
And this is where your clinics come into play.
Correct.
By and large, if you have a fracture which is on the horizontal surface of the tibia and does not reach to the posterior vertical part, they usually remain stable. They don't have a sag, they do not have a posterior drawer. They do very well with conservative management. I mean, you can push the envelope and do the surgery, but they'll do just as well without it. If a fragment is in the posterior part, and even if you have a slightest amount of posterior drawer, I think they need to be fixed, regardless of the size. It's the part of the ligament that is not viable. Having said that, small comminuted fragments have historically been treated very well conservatively. So there is a role for conservative management if there is some reason why you do not want to operate. Does that answer the question?
Yeah. Thank you, sir. So does age, so young patient, old patient, male, female, does it change our management?
Age as such,
Like type 2, type 1?
as such, not so much.
Okay.
And as I'm getting older, I find that my expectations are same now as they were 20, 30, 40 years ago.
Yeah.
So not so much, depending on the biological age of the patient.
Right. Right, sir. So the management, it depends on the options, type and size of fracture, amount of displacement, combination and other associated injuries. So coming to the management, so how we decide whether it is an open reduction internal fixation or arthroscopic, sir? Is there any specific protocol or reason you do open, you do arthroscopic?
If it's a big chunk, it's significantly displaced, then you decide to do operations. And my favorite is direct posterior approach, open approach, and nice fixation, just like any other intra-articular big segment fractures. Because there is a significant amount of pull fracture, and you can jolly well fix it with 1 or 2 screws in proper direction if you go from bank posterior.
Yeah.
If it is comminuted, then it is a role of there is a role of arthroscopic and non-screw fixations.
Same. So there is no for juniors also. So arthroscopic, there is not much difference between open surgery and arthroscopic surgery. And there is a beautiful technique demonstrated that even a small incision like 5 centimeter will do you have a screw from posterior to anterior. I think there is no harm in opening it. So because rather than struggling for hours to get your posteromedial portal with not kind of visualizing thing, so open surgery have a role, and there is results are, I think, at par
Almost
by,
identical.
Arthroscopic surgery. So it's about whatever you are comfortable with, whatever armamentarium you are having, and your expertise on that.
See, I'll tell you, with the kind of work pressures and difficulties we face, the times, a 15-minute surgery vis-a-vis 1.5-hour surgery makes a difference.
Yeah.
The first one is a 15-minute surgery. It's direct visualization. So 90% of the work I have done on PCL avulsion is open fixation.
Yeah.
10% is because of my love for arthroscopy and to hone my skills. I won't say it will benefit patients more, or it would cause, but what I have realized is I take much more time and it adds to the pressure of my work also, and therefore pressure on my patient also. So it doesn't really change anything. I accept, and I am telling that I have fantastic experience with open reduction. So absolutely, but yes, for the sake of learning, doing arthroscopies, I have not found much difference really.
Then sir.
So as per me, the only indication of arthroscopic fixation is when the fragment is very comminuted or it's small, and sometimes when it is osteoporotic. In that case, you won't get good screw purchase. So probably that is the relative contraindication of screw fixation, and in that case, probably arthroscopic fixation should work better.
So that's where we catch the base of the PCL rather than the fixing with the bone chunk. Right, sir. Thank you. So one arthroscopic one advantage is if you have any concomitant injuries, or if you want to look at any other injuries, there the role of arthroscopy comes where you can simultaneously address the other issues. So depending on fixation devices, sir, like any role like different screws, suture anchors, endo buttons, or only fiber tapes, any role, one is superior to other, anything like that?
No, big chunk. Obviously, put the screw in proper direction.
Yes, sir.
After what, because sir, Kanchan sir was, Gigi sir was telling, I think arthroscopy just gives you the pleasure of doing the thing.
Yes.
Even in the comminuted fragment, if you use the suture anchor, you can do 15 minutes job. Why you complicate with 1 hour, 1.5 hour job? It is just the satisfaction sake of doing it. I can do it arthroscopically manage. PCL avulsion, I do it when I have a lot of time. Or else just open it, do it, fix it with the anchor. You can even drill with the ACL jig from the back to front. Even if whatever the comminution, you just pass the suture things around your comminuted fragment. You can pass the sutures in the front. You can tie on the lowermost picture like your button. So it is easy job to open, and it is safe, plain, no harm. Previously when I think Kanchunda was doing the PCL, we used to do the typical big ace incision, doing the popliteal dissections and everything. Nowadays we are not even going to the popliteal vessels.
Right, sir.
It is much more medial incision. So I think open approach is the safe technique, reliable technique, and we have to set off the ego of being the arthroscopic surgery at this point of time.
Right. So the consensus is we should do a safe surgery and have a very good reduction rather than whether you are attempting arthroscopic or open procedure. So what will be the rehabilitation protocols, sir, like immobilization, if you are doing open or an arthroscopic? Because most of the times they end up in stiffness.
Arthroscopic, and if they're usually fairly recent, I mobilize them a lot sooner. I get them on partial weight bearing from day one and immobilize them for 3 to 4 weeks. That's about when then I start the mobilization, as opposed to PCL. And this is the only difference between PCL and PCL avulsion, because this we relied on healing much sooner and we mobilize them a lot sooner.
Right. So when we'll start the range of motion? in these patients. 3 weeks. Right. So these are the other common complications: non-union, post-traumatic arthritis, and stiffness. So what about these delayed presentation? Some patients will come around 6 weeks, 12 weeks. So what will be our management or our protocol? Still we'd go and fix it or bone graft or do a direct reconstruction at a later date. So how will approach
Never
this?
used a bone graft even in a 6-month-old patient.
Yes, sir.
Never.
Treatment is same as our non-union of the fractures. So you have to open up the fracture. I think arthroscopy is after 6 weeks is not comes into play much, because you have to open the fracture and freshen it up, get the raw bleeding surface and just fix it. I think that's the principle.
Now my question is still how long we attempt for fixation? And when we...
Yeah, if it's an old one,
Yeah.
even with a large chunk, exactly what I would do with an old ACL version. I would
Right, sir.
reconstruct a PCL.
PCL reconstruction. Right. So I'll just show a short case presentation. It's a 32-year-old male, RTA, left knee injury, 2 weeks. So that's the posterior big junk PCL avulsion. So that's with probing the fragment. So done with an adjustable loop by suture pull through. That's an ICL jig we used, as sir said earlier. So drilled through that. So pass the loop wire. And pull the button and reduce the fragment onto the avulsion fracture bed. So that's the post-ops. Thank you, sir. Thank you so much.
One question. Suppose you have decided to go for open reduction internal fixation of the PCL avulsion fragment, and after opening it up, you find that it's comminuted and you can't put a screw. So what all techniques you will adopt to do the fixation? Whether you pass the fiber wire and go inside and make a drill hole and fix it anteriorly with the suture disc or endo button?
You just answered it.
Yeah, any other technique?
You just answered it.
I am asking you whether there is any other way how to do it.
There could be other ways, but this is one technique that we all know.
Okay.
And it makes it easy, you know. And now with all those, all the dog buttons and adjustable loop that you have, you don't have to flip the patient all over again. You can tighten it from right from the back.
So coming to the second case, so I have 2-3 cases, but I will go quickly through one case because we are running out of time. Welcome all the delegates to this case-based discussion. So here is a case of 32-year male with history of road traffic accident 3 weeks back. From the first presentation, complaining of pain and instability of the knee. On examination, there is a healed abrasion over the tibial tuberosity. Posterior joint line tenderness was present, posterior sag was present, range of movement was 0 to 100 degree, posterior drawer was present, quadriceps present, no mediolateral instability and dial was negative. So when we did the first imaging, this is the picture. Gigi sir, so what is your diagnosis and how you proceed from the X-ray?
So it's according to your findings, it's
Clinical findings and the X-ray.
Unidirectional posterior instability.
Yes, seems to be.
That is the diagnosis, but the cause is here. A small bone fragment is visible posteriorly, but I am not sure about what is that.
Okay.
It doesn't look typical kind of avulsion of PCL, so I am not sure about that.
Okay. So, Somyadeep, do you want to do anything more, or straight away you will go from this diagnosis? As Sridhar presented last case.
Of the patient, obvious.
Okay, MRI of the film. So this is the MRI film of the patient. So you can go through these 2 MRI films. Because sir, so what is your diagnosis right now? Is a PCL avulsion or something else, or a combined injury, or what you see in the MRI? This is the sag image, coronal and axial images.
Go back to the sagittal.
Yes.
It is a PCL rupture. It is an avulsion.
Correct.
There is a reasonable amount of posterior capsular injury.
Okay.
And there is, if you come back to our the other image, the image which you showed,
Yeah, this is the image.
in this image, I am not able to see the popliteus properly. That image is missing. It's missing. No, popliteus is there, but I can't see the tendon of popliteus. That's the image missing. And the LCL looks okay. I mean, the MCL looks a bit on the tibial side. It is giving some trouble, but it should be all right because femoral side is good. And if I look at the patellofemoral joint, which is not very clearly visible, not really, I can't say much. So it is probably a gross posterior injury. Something may be happening in the root of the medial meniscus, and there is a tear in the medial meniscus in the posterior horn also, which is I can see that thin sliver of line going into the medial meniscus. So probably there is a meniscocapsular junctional tear plus a meniscal tear. Yes. Something else?
Okay. Kanchan sir, do you agree with the diagnosis of Vikas sir, or you need to add anything more?
No, he has found a lot more things than I did. Essentially, I think it's a pretty...
Yeah. Sonendu sir?
No, whatever you see, there is injury, lot of soft tissue injury in the front and back, more on the back. There is also some compression on the front of the lateral condyle of the tibia. Also, if you see the coronal picture, then you will see that there is bony impaction and bone edema on the posterior medial corner of the posterior condyle of the tibia.
Posterior. Okay, so the PCL is torn from here from the femoral attachment, but when you come to the tibial attachment, certainly the PCL avulsion, which is apparent in the X-ray, is not seen over here. And when you go to these sections, you can mark something right over there. What is there?
No. If this
or do you want to do something, some imaging, some extra imaging?
You can do the CT scan.
Okay.
Better
So here is the CT scan. So
that I was referring to. If you go back to the coronal picture now, then you will understand this. Go back to the coronal picture.
Okay.
Then you see, if you go the coronal picture, if you see suppose this is the left column.
Okay.
If you go to the second picture, then you will see the edema around the back of the posterior that I was referring to.
Correct.
So that is the signal that is giving you the picture that something has been avulsed from that part. It is a posterior medial corner injury.
Correct. So when you see the CT picture in the medial films, there is a fragment over there. Something has avulsed out from the plateau. But when you come to the PCL attachment, there is nothing, no avulsion. So when you correlate with the coronal images and the 3D reconstructed images, certainly the posteromedial tibial plateau, a little bit of posteromedial tibial plateau is avulsed. So the diagnosis from here is a PCL tear with suspected meniscus root tear was Vikas sir is telling, and with tibial plateau, little bit osteochondral fracture is there. So we went for a diagnostic round. You can see the PCL is completely torn from the femoral attachment. So we went for creation of the posteromedial portal to have a good view from the posterior side as well. And then we debrided this PCL from anteriorly for the PCL reconstruction, which is planned. There is hardly any remnant left, so we sacrificed all the remnant. There is no question of remnant preserving in this case. And when we went further posteriorly, completely there is a root avulsion from the medial condyle root attachment side. And when you go posteriorly again from the posterior medial portal, if you can see, there is a certain crater under this meniscal root avulsion. You can see the raw bone one from where the cartilage has been avulsed out. So, so from anterior side, when we lifted this meniscus root, you can see, so this is a cartilage fragment. So, right now the diagnosis is the PCL complete tear with meniscus root tear with a small osteochondral or chondral fragment. So, Swarnendu sir, what is your plan right now? What do you want to do? How you address that fragment, how you address the root, and how you address the PCL?
No, you take out that fragment. No point in
You take out the fragment?
No point in fixing that small chunk of bone, whatever you have seen in the CT scan. It is just for then you fix go ahead with the root fixation, whatever the best possible way you can do it, and then go with the PCL reconstruction. Patient will be happy, surgeon will be happy.
Okay, Amrish.
Sir, anyhow, that fragment is not coming in the ROM, I think, the posterior and posteromedial fragment. So better to just excise it. Otherwise, that will act like a loose body later on, even if you try to fix it. So better meniscus avulsion fixation and PCL reconstruction.
Kanchan sir, do you think that little bit of chondral fragment will cause some posteromedial instability kind of thing in the
This
patient?
small fragment that you have, is the root kind of attached to that fragment?
No.
No, it is not.
No.
You know, we are going to repair the root with the same tunnel. I'm going to take the small fragment into that raw area, and then tie it out.
How you will take the bites through that fragment? How you will fix that fragment?
I won't take it through the bite. I'll go around it.
Around it?
Around it, from the front to the back.
Okay.
And we already have a posterior portal to see it and guide it. So since I'm going there to repair the root, I've got a couple of tunnels. I'll just add one more tunnel to this and bring all the sutures down and tie it in the front like I would do the root.
But that fragment is not coming onto the bone. So will you take some traction sutures?
If it's not coming onto the bone, then I will sacrifice it.
Because sir?
See, I have a suspicion. The suspicion is that it may not be that root is attached there, but this fragment is definitely attached to something which has rotated it.
Yes.
Okay. So once, and that has to be meniscocapsular root, meniscocapsular tissue. So there is a capsule which is communicating and joining this fragment along with the root, or along with the meniscus at the back somewhere. So once I reduce the root, most of this fragment will be pulled back into that area which is raw. Once it is pulled back into that area which is raw, and I have attached the root very securely, I will not attach the root by one single tunnel. I will probably drill two tunnels and do
two root tunnels.
Two root tunnels and attach it, trying to take one tunnel through the fragment if it is stable after attaching the first tunnel with the root, first root tunnel. Okay, then try to take the second tunnel if I need it, if I find that I will get more stability with attachment of this fragment and passing it through the posterior capsule and the root both, posterior meniscus both. So that makes it very tight, just a minute. And then after that, I will probably align my PCL reconstruction tunnel, trying to keep it away from the root tunnels so that they don't coalesce, and do a standard PCL reconstruction.
Okay. Somyadip, with two root tunnels, do you think there is a coalition with the PCL tunnel? Quickly.
No. I am going to excise the fragment, do a PCL.
Okay, excise the fragment. Gigi sir, so PCL reconstruction, single bundle, double bundle, what do you think?
One bundle.
Single bundle. Root tunnel, single or double?
In this case, one.
Okay. So, with this feedbacks from the panelist, so there is a paper, very good paper from the Rob Laprad, recently in 2022 for the optimal tibial tunnel placement in case of root fixation in ACL PCL reconstruction. What was thought previously, the initial tunnel configuration, if you are creating these root tunnels above the ACL or PCL tunnels, so So there is a chance of convergence of this tunnel. But the new reoriented tunnel configuration, what they concluded, to avoid the tibial tunnel convergence when performing ACL and PCL reconstruction with medial and lateral meniscus root repair, surgeons should reorient the meniscus root repair tunnels to be parallel on the sagittal plane to the ACL tunnel to decrease the risk of convergence. And in case of bicruciate ligament reconstruction, use of double root tunnel technique requires caution to avoid convergence risk with the PCL tunnel. So if you can, you make the ACL PCL tunnel constant, and then you create these root tunnels below the ACL PCL tunnel so that it will not be converged. So what we did in this case, very quickly, 1 minute video, we took the peroneus graft for the PCL reconstruction, and then from the posterior medial portal we fashioned off the crater. The fragment was loosely attached to the posterior capsule, and so we took out that small fragment, and then we took the bite through the meniscus, and we created the root tunnel at the edge of this crater, and kept this root tunnel, this reamer in place, and then we took 3 bites in the root with the fiber tape. This is the suture tape, and next one with the fiber tape, and third one with the fiber wire. So all these sutures, we took the luggage tag sutures in the meniscal root so that it will have better hold for the fixation into the crater or margin of the crater. And once we did that, then we parked these sutures and did the PCL tunnel. So when we did the PCL tunnel, we kept this root tunnel guide wire and the reamer in place so that there will not be any tunnel coalition, and we created a parallel tunnel as you can see over here. Then we pass the sutures through those tunnels, and through a bead pin we first pass this leading suture, which was after creating this PCL tunnel. You can see they are not converging over each other. This is the root tunnel, and the adjacent one is the PCL tunnel. Then we retrieved the suture from the PCL tunnel. Then we created the PCL femoral tunnel. You can keep the PCL the tunnel reamer very close to the articular cartilage margin. Then you pass the guide wire so that you will have as close to the articular cartilage as possible. Then you remit with the 4.5 reamer, pass the suture, pass the tendon PCL graft. When you flip the graft, then you shorten the graft with cinching movement so that the PCL will go inside the PCL tunnel. And then we take all the sutures from the root onto the tibial side, and then fix the root on the tibial side. So we are taking all the sutures through the tibial root tunnels, and then giving a little anterior drawer force. First we fix the PCL with the help of a screw. You can see the meniscus root, and with the help of a bio screw the PCL, and then with a dog bun button the root. So they are the parallel tunnels, so they are not converging on each other, and this is the final post-op X-ray. Thank you very much all the panelists and the delegates for attending this panel discussion. Thank you very much.
Thank you, sir, for this very intriguing discussion.